panel that represents all of Colorado and captures a spirit that I believe is going to carry us through this work. It is really special to have such leaders here. I think you have the information and the background on our panelists. So I want to jump right in, and I'd like to start with what is a innovation methodology known as design-centered thinking. How many people have heard about this methodology, design-centered thinking? All right, pretty good showing. There's a range of books that you can read about this, but more importantly, it's really doing it. And the spirit, you'll hear this phrase sometimes, is you come up with some hypothesis, you build something, you test it, and then you iterate. It's just what Jamie just said. We have to be willing to try some approaches, see how they work, learn, and adapt. How do you come up with a hypothesis is where I want to start, and I really want to start by giving Commissioner Laske the first chance to talk about this, because it's the theme we've already been building the conference. It's listening to people who've come through lived experience. And that's, by the way, one of the core premises of design-centered thinking. You often think about it as empathy or user experience, which is what does someone go through. You have so leaned into that. I want to understand a little bit why you got that as a core value, and then how has it helped you designing solutions?
Thank you. Well, first of all, when in our region we looked at really what we wanted to do and start the development of this 2-year plan, and what we realized is we had a lot of gaps, but we also needed a lot of education and really introduction to it. I live in a rural area where everybody says, oh, that doesn't happen here. That only happens, you know, in big cities. Well, it did. And that's where we really needed our lived experience people to come in and help us. I just announced, I kind of feel like that is my job, is to work for them, as opposed to them, you know, they share that information that we need, that there is no way I would be able to have that perspective of going through it. Just to put out there, when we started, we only had one peer that I can tell to the best of my knowledge, one peer with lived experience in the San Luis Valley. And I'm so excited to say we have now got a group of 8. We have 4 of them that have started with to become certified. So I want to be practical about this.
I just want to, we're 1 year into this, and in 1 year you went from 1 certified peer recovery counselor to 8.
Yes, and I think our first 4 are going to be certified here pretty quick. And I think you have to be purposeful. So actually what I would like to do is I have some of our peer council members, our peer professionals in the audience. Would you guys stand up, please? Because this is what we're doing it for. And I can tell you, I could not do my job without these people. This is the drive, and this is what gives me passion. And I want to share a practical experience. So I came in and I knew peers were important. And yes, I'm starting to talk fast because I get excited about this stuff. The first thing I wanted to do is we need peers. So I looked up, how do we get the training? How do we get them certified? How do we get them going? And then I'm sitting in a meeting, and in particular, my Tony says, you know what? We need some social events. We need more than just this certification. We need that camaraderie. I need to know that somebody has got my back and protecting me. And I just sat there in the meeting for a minute and go, how did I miss that? How did I miss that? This is incredibly tough work that our peer coaches are doing. This is emotionally taxing. And all I was worried about is get them certified and get them out there to helping. That's why I need them. So we actually pivoted. We took our plan, and instead of the funding just for the training and just for that certification process and the testing, we have set aside some of those funds, and we have kind of what is called an association of our peers. So all throughout the San Luis Valley, our first dinner is coming up. It's a social dinner. It's an opportunity to get together and for them to share with me what are the challenges that you're having so I can go out and do my job and see what resources we can bring into it. That is for me to say, okay, I'm going to be reaching out to Raquel and say, I need some supervision, or I need a mentorship, or you know what? We just need to have a good dinner, sit down, have some tacos, and say, you know what? We're doing a good job. And that's an element I missed until they brought that to my attention. And that's the power of peers and the power of listening.
So I'm going to go to the other side of the panel. Dr. Ryan Jackman is up the road, as it were, at St. Mary's, a doctor specializing in addiction medicine, a core part of the Region 13 effort. There's been a lot of literature about the importance for doctors to listen to patients. This is an idea that I think is resonant with what Lori said. For you, as you think about designing solutions, how do you think about that dynamic?
Well, I think to echo what the commissioner had pointed out is that as we listen to our clients, our patients, our peers, our community, they have the answers. And as we, whether I'm sitting in my office talking to a patient or whether I'm sitting in our abatement council meetings in Mesa County, you know, our recovery specialists show up and they teach us what they need. And one of the innovative models that is the next step, Commissioner, for what you are all doing down there, that is being highlighted nationally, but that we are seeing work exceptionally well for my patients as well as our county, is having a space for recovery that is in the community where these people can go and spend time together. As you pointed out, connection is the solution. Isolation is the problem. And having that joint space where they can be together in person and that it is recognized within the community by people who may not know anything or have a personal history with recovery or addiction, but it's recognized that this is a place in our community of safety, this is a place people can go, and they're getting referrals from all places, including my office. But the number of my patients who come back from having spent time with our recovery community organizations in their space has been phenomenal. They make so many more strides towards maintaining their recovery than just sitting with me in my office for 20 minutes and talking about their goals. And so that has been, I think, one of the innovative models that I have seen be so successful in regards to recovery.
MJ, we're going to get to hear a little bit about what you've done up there in Larimer and Well, but let's stick with this lens because I know how centered you are on supporting people in recovery. Talk about that philosophical commitment and how did it develop and how has it guided you in Coast Law's journey?
Yeah, that's a big question. But I think to really start that off, it starts in trusted relationship. We can't do this work without each other, and we certainly can't do that work without the trust of each other. And so it's one thing to sit next to Lori, but it's another thing to build a relationship with her. Our peers, to that point, trust each other. They build relationship across our teams, across our regions, across organizations. Our team is not the only one who is holding peer-based work. And so how do we kind of bring this ecosystem all together so that I know, Kyle over at this organization is a better fit for the client who's in front of me today than I am. Let's do a swap and a warm handoff. And that trust across that organizational boundary is really what's brought our peers as a region together, not just our peers as an organization.
So we're going to talk more about Coast Law, and the idea that you've been able to implement is basically to take everyone who's a service provider, an addiction specialist, whether it's a peer recovery coach, whether it's a doctor, nurse practitioner, and you've built an integrated system where you can collectively know who is struggling and needs services and be able to, as you put it nicely, collaborate, make warm handoffs. I want to come back to how you build such a culture, because I think it's a pretty important story. But first, any thoughts on this in terms of listening to people who are affected and who've had lived experience from the chief?
You can't serve somebody if you don't know what they need. First of all, you've got to know what problem you're solving. I'm a law enforcement professional, I'm educated, but I've never been addicted to anything. So my approaches will have the potential to make things worse if I'm not listening to my colleagues, if I'm not listening to my organizational partners, and if we're not truly paying attention to the needs of the people they serve. You can dictate what people want, or you can give them what they need. And you don't know what people need until you talk to them and have really open dialogue, like what we're doing right now. This is not communication, this is messaging. Communication implies it's human. It's more than just the message. So you've got to be on the same level, there's got to be a common understanding, and you've got to get feedback. And that's, to me, that's what it means to understand what people need.
So I want to go back to you, MJ, because you gave us the accomplishment, the outcome. You have built a culture with deep trust and close relationships across a range of providers who are collaborating. That is an extraordinary accomplishment. That culture includes those in the emergency rooms, it includes those in law enforcement, it includes an awareness of shared goals, and it's providing a level of actual service that is probably higher than almost anywhere in the state. And it was a journey that started with a grant you wrote. So I just want to hear, how long ago was that grant you guys first did?
Yeah, actually the origins came from when we started to see this flood of prescribing of opioids, and then folks losing their prescriptions and then turning to heroin or other substances.
So what year was that, would you say?
Ooh, 2013, 2014.
And so you guys have now been at this for a decade, sticking with this point about culture, because Lori explained very well her efforts to build a culture. You've now had a decade into it. I'd love for you to start and then Lori to follow up, which everyone here in every region is thinking about this. How do you build a culture with trusted relationships to be successful for the long term? Because if you have a region and there isn't trust, there isn't real communication, there isn't alignment, you're not going to be successful. So talk about how you guys have done it and are doing it.
Yeah, it really comes down to a shared need around a shared issue, right? And understanding that the solutions that we've been using have not been working. And so coming to the table, putting our pocketbooks down and saying, how do we actually work on this, regardless of the organizations that we represent, and build something different, build something new. That energy of building something across a region is something that is unmatched. That is the secret sauce that brings people together. However, getting folks to the table is an entire project management structure of its own, right? And so the coffee dates of it all, getting people on the same page of I want you to be a part of this solution if you're interested, and I want to understand why you're not if you're not. And using those champions in different sectors, those cross-sector champions, and saying, well, here's somebody in the emergency room who's willing to work with us. I'm wondering if you'd rather talk with them about why they're interested than me. Maybe that relationship will be different to bring you into the fold too. And so we actually have continued all of those partnerships, those relationships through several regional working groups, one of them being the Northern Colorado Collaborative for Addiction and Recovery, previously the Northern Colorado Opioid Prevention Work Group. We love an acronym. One of them's easier to say, NOCO cares. We love that for us. But it's because we keep bringing people together and building relationship that they keep showing up when it's time to write a grant. It's important to have people at the table before there's money on the table too. And right now we're in a very unique space where there is more money in behavioral health than there ever has been, and if we work together, they will be better spent.
Lori.
Oh, wow, we're working with people, and that's the toughest job in the world.
And just so people know, how many people do you have on your regional council right now?
We have a pretty large board. We have about 52 people on our council. I shouldn't say about, we have 52 people on our council. That's between the voting members and the non-voting members. And I have to tell you, our non-voting members are people within the community that have the expertise. So let me go back. I did some research. I'm a numbers person, and I was kind of wondering about when in the San Luis Valley did we become aware that this could be a problem. And I have a funny story. In 2011, we had a pharmacy broken into. They didn't touch the cash register. They went after the pills. And I think that was an aha moment in our area to say, this is verging on a problem. So this has been going on for a long time. I came into this when I was elected to the position as a commissioner, so I was very new. I needed to reach out to the people in our community. And as MJ said, I want you to be involved. I was a little more desperate. I grabbed him by the arm and I said, I need you to be involved. They all knew we had this problem and this urgency, and they were all working, but they were somewhat working in silos of how to fix it. And so for us, it was really an opportunity to come together. And many times when you sit in our meeting, I'll say, hey, who does this? In fact, just the other day, I was like, now tell me again, which of our organizations are offering MAT, or medically assisted treatment? Which of our organizations are doing full case management? Which ones are providing transportation? We have someone. And I truly need, in fact, Melissa Dominguez is sitting in the audience here. She is one of my go-tos. I need those people. So I think it becomes an area of mutual respect. The other thing is that I feel is this is also reciprocal. So they attend my meetings, but if Melissa has a recovery day in the park or something of that sort, I show up to that too, because we are truly a team. And so we hope that we are there for each other all the way through. And yes, I will go back. Lots of coffee. Coffee works very well to bring these people in, but you need to have that mutual respect, which I do. I admire and respect the people I work with. I have an amazing council. 52 people are hard to wrangle, hard to get together, but I need every single one of them. And many times I'm reaching out to the physicians. We have a couple of physicians, a pharmacist. I'm like, what are you seeing? What am I missing here? And I think that's a lot of it. And of course, communication, to just sit down and say, what am I missing?
So that level of humility and respect for others is so powerful, because one could imagine the opposite version of even a smaller number on a region where people weren't listening to one another and were acting without the cups of coffee in ways that the other people felt like, why aren't you listening to me? Why don't you respect me? That's a pretty powerful currency that you're building. It does take time, Ryan, and doctors are known for being very quick to want to move on. In fact, there's studies about how long doctors listen to patients before starting to diagnose them. And I think it's 11 seconds or something like that. It's less than that. Yeah, so how have you built the patience to do this type of work, and how are you in Mesa County really off to the races? So I think when we looked around the state, some communities were kind of ready and others had more work to do to get ready. You guys were ready, so I take it there must have been some relationship building already happening before this opportunity.
Yeah, I think Mesa County had the advantage of having had funding prior to this funding that had brought consortiums together. The people that were missing from the consortiums were our elected officials, actually. The medical providers were meeting regularly to talk about what was happening in the community, what were the patterns.
Is this starting with, because I went to one of these meetings, the Rocky Mountain Health Plans had these community conversations with all the medical. So there had been a culture within the healthcare community, but
Yeah.
that hadn't included the elected officials.
Correct. And so we had the medical group together, we had the recovery group together, and this morphed into something that then has been taken on by the health department and now by our regional education center that runs these monthly meetings. And then we had layered that with a rural communities opioid response program for the federal government that included Mesa County, but also the surrounding counties. So we had the advantage of knowing what was going on in our area, but also in the regional areas that work together as far as medical referrals. And so we did have that baseline, but I think to your question of patience, that definitely helped us get to the point where we understood one another, and the mutual respect and the curiosity that had been brought up definitely served that. But what developed out of that is the realization that the people that were at the table had expertise and passion, and we wanted to leverage that expertise where those people were. And it's this culture of, how do I do what I do best and allow you to do what you do best so that it becomes something that builds on one another. There's some synergy there, as opposed to me trying to do what I think I do best and getting in your way.
So this is really important for everyone here as a regional leader. Listening to people's lived experience, integrating the public health, the healthcare professionals, and having elected leaders all together. I can't imagine, and I've been to many communities where it's clear the public health professionals and the elected officials don't even know one another. So that is an important element. It's really impressive what you've been able to do in Grand Junction. We're fortunate to have Chief Gordon here because you have experience in other states knowing that this type of collaboration is not the norm. I think I've already mentioned that. Talk about what you've seen in Colorado and how you've seen it in Adams County, your community.
I've been here since about November, December of 2020. I came from a different state. And while there's cooperation, collaboration is not unique to Colorado. But what I've seen since I've been here is a willingness to work together, a willingness to look outside of our own organizations, which is extremely important for senior leaders. You have to look outside of what you do if you truly expect to serve the people that you come to work to serve every day. So it's just been tremendous in Adams County. If an agency reaches out, everybody's there. We meet on a regular basis. We do know each other. The Opioid Council has even allowed me to meet other people that I never thought would have any impact on what I do. And the initiative that we've been able to put together as a result, I believe that we'll be able to do things in our city, hopefully replicated in the county.
Talk about what you're doing, because it's a really great story.
It's the seed of it is a Naloxone Plus program, which when we started writing the grant was already in effect in about 100 jurisdictions around the country. But there were none in Colorado. And a pure Naloxone Plus program, outreach is initiated when a person is revived using naloxone. Public safety, first responders, we revive a lot of people on a regular basis, and then we go like this and tell them to go out there and be somebody. That is a tremendous loss of an opportunity to save somebody's life, because when they revive, it is highly likely that they will have another overdose. And this stuff is deadly. We have seen people go from robbing Walgreens to get it to not having to rob Walgreens anymore because real heroin and the synthetics are cheaper and easier to get. But what we're doing, there are more pathways to inclusion in our program. It can be the naloxone revival, self-referral. We're going to engage in a campaign of outreach. That's me though.
You could be outraged by a number of people.
No doubt.
That's okay.
A campaign of outreach, and also we're going to train our officers and our firefighters, hopefully, to intervene. So there's going to be rapid identification, rapid engagement, rapid referral to treatment, follow-up, because we're hiring therapists, we're hiring clinicians, therapists to actually manage these cases, and then partnerships with the right resources. Hopefully we'll get to this peer support level as well. That's another thing that we hope to do. But also, there's a piece that defers these cases, diverts these cases when it's appropriate from the criminal justice system. People say, well, then why do you need the police? The fact is, unfortunately, 911 has become the social service agency, the human service agency of last resort for many people, for most people, as a matter of fact. So it's incumbent upon us, because our net is so wide, it's incumbent upon us to do more. We say it's not a police problem. It's not, but it's coming to us anyway. So until we're able to put it somewhere else, we've got to do what we can to achieve our missions to protect, serve, and save people's lives.
So one thing we'll be doing over time, and Jamie is truly extraordinary in her ability to capture all this, is we're going to build best practice ideas that different regions can consider, and that we can learn from one another. Now, MJ, you guys are doing an incredible amount tracking and supporting those who are struggling with addiction. Have you guys done this yet in Northern Colorado?
Intervened at.
So basically the idea is, if someone is saved with Narcan, and I think Rick Brandt is here, we owe Rick a real appreciation for how much work you've done on evangelizing about naloxone. But Chief Gordon's right. Often, the norm is you save somebody and then you say to them, good luck to you. As opposed to, we're going to make sure you get connected to care and we're going to stay connected to you. Have you implemented that yet?
Yeah, we have started improving our partnerships with our co-responder teams in particular. Larimer County has been all over that, and the folks that they engage with substance use or overdose of any kind are referred into our services. But similarly, if they're brought to the hospital, we are part of that hospital workflow.
That I know, yes. This shows how much coordination is critical. We've now gone down a list from people with lived experience to public health professionals to government leaders to law enforcement. Let me add one final question, then I hope I can get time for a question or two from the audience. As we try different experiments, including the one you're doing, some of them are not going to be successful. One of the critical elements of trial and error learning or design-centered thinking is to pivot when you learn this is not working. That is so much easier said than done, particularly for people in government who don't want to pretend that anything doesn't work. So, Lori, how are you approaching that, and how should others think about that? I can tell she was afraid I was going to ask her, so I couldn't help but ask her.
Well, when Attorney General Weiser asked me to be on the innovation panel, I said, is that because I go from treading water to back floating to treading water again, just kind of working through the process to stay afloat? Which it wasn't, but I wanted to do that. Let me go back to an example. I think the first thing we have to do is remember this is a marathon. So to get that mindset that we have to be persistent and not everything's gonna work, because I want things done yesterday, I'll be honest. We got those funds, I wanted everything to go like that. And here's my example. We created this fantastic RFP. We put it out there, having somebody come in and do this and innovative. Guess how many applications I got? Zero. So the committee I had set up to look at this, we didn't even need to meet because we didn't have them. That is where we had to stop and pivot and say, okay, what do we have in that scope of work? What are we asking for? Did we ask too much? Those are the type of things that are more difficult than what you anticipate, because we lost a month in that process of waiting for that happen, actually going on 2 months. We have now changed the RFP, changed the scope of it, narrowed it down a little bit, and we're going to put it back out. What we did with the elements that we removed, we're going to do that as a contract employee. So it's always kind of that puzzle box of you pull one and then what do you do in the next one to make it work. So most definitely, pivot is kind of, if we ever create a logo, it'll have a pivot in it and not a sprinkler pivot. So, thank you.
Thank you.
Yeah, I mean, we have to do this every day. We get feedback from our staff, feedback from our clients, community partners that, you know, this could be modified, adjusted, completely scrapped, all of those things. We just have to eat that sandwich, that pride sandwich, and move forward, right? That said, most recently, I'm looking at Will, one of my supervisors in the back. He has been working to build out programming with the Weld County Jail for MAT induction and continuation. And we weren't getting a lot of follow-up calls from folks after they were re-entering. And he sat down with a couple of our peers and said, what does this document need to look like for when you get this monstrous stack when you leave jail? And he made adjustments to that. The peers were like, we're good to go. And we're actually receiving more phone calls. So it's
Great example.
stuff as simple as that modifies the way people can engage with you. But if you're not willing to have that feedback come to you, you're never going to get that alternative outcome.
So, Chief, not everything you try is going to work. How do you create a culture that it's okay to learn, okay, this didn't work, we got to try something else?
Well, first of all, you have to innovate on a regular basis. You've got to put the right people in place, you've got to make good decisions, and I always say this, success is a hell of a motivator. So if your agency you have a history of success, you have a history of positive innovation, then it becomes second nature to look for opportunities and then to not do the things that aren't working. It's not failure. It is not failure to admit that something isn't working. And that's why the assessment piece is so very important. If you're doing robust assessments and everybody's engaged and you're communicating, it doesn't look like failure when you say that this doesn't work. Leaders have to eat that pride sandwich and communicate regularly with people. We're going to try this. It's not reckless. You're not making reckless decisions. You're taking informed, calculated risks, and those things have to be communicated to people on the front end. I think it's simple.
Easier said than done.
I think that what we are trying to do over the next 18 years lends itself very well to this concept, which is we are working on addressing substance use disorder. And for my patients who are in early recovery, they themselves understand that this is a chronic, relapsing, remitting condition, and it's going to take changing how we approach it. We're going to try this. If it doesn't work, we're going to come back and we're going to work on something else. But the goal at the end of the day is recovery, and I do think that we have the right people at the table, and continuing to bring more of the right people at the table will help us to be successful. I think one of the ways that I have seen this, or a couple of the ways that I've seen this in our Western Colorado community, we have here in Montrose Delta, and one of the work groups we have, a number of patients who are not necessarily coming back after they've been started on MOUD, and they said, well, how can we address this? And the Delta County Ambulance District said, we have health workers, we can go out for you. We'd like to move to the point where we can start buprenorphine in the field with policies and procedures so that if somebody has an overdose, they get started right there. We have a group out of the university that's working all over the state with pregnancy and addiction, and they've said, we have peers, they want to get involved, but we're having a hard time keeping them involved through the labor and delivery process. What can we do? They said, well, let's train them, cross-train them as doulas. Now they're in the room. This is a great pivot that has been very helpful. Mesa County, we said, well, we're going to give this money out. We've seen situations where either on our side, we haven't been able to meet as frequently and stay on top of this, or on the recipient side, they have great ideas, but they don't have maybe the business infrastructure. And so to address both of those conditions, at the beginning, Mesa County said, we are going to hire a third party to help manage our grant so that they are on top of this. They are collecting the data, they are reporting to us on a regular basis so that we have regular inflow of data so we can make decisions, and the commissioners, who have a number of other things on their plate, aren't trying to collect this on their own.
So some more ideas for the chief here. After your first pilot, you then start more from right away, and you assign them a peer counselor. So, yeah, there's your encore for you. All right, questions from the audience, thoughts, ideas? We have a few minutes. And there's a yellow mic right here. Come on up so we can hear you. And please introduce yourself.
It's a little low, it's like my height here, so.
Hello, my name is Katie, and I am an addictions counselor because I was first a peer, because I was first an addict, so I'm in recovery myself. My question is this: so as I've heard all day yesterday and today, how important it is for peers, and I love all my peers who are out here, and I just think that peers, as you have acknowledged, are important. The problem that we've ran into is that while it's nice that we can have the funding from the grant for peers and for peer support, what happens when that runs out? The payment reimbursement from Medicaid for peers is so minimal that that's not a sustainable program. So we have all of our patients who are getting through their program, thank you, who are getting through their program with all this peer support that is just gonna drop at the end, because the Medicaid, I'll tell you, I don't know if you know, Medicaid reimbursement for a peer is $16, if that. How can I hire somebody to sustain a peer program when there's no reimbursement? So that's my question.
So in our agenda for federal leadership would be raise that reimbursement and allow Medicaid reimbursement while someone's in jail, which is another huge disabler. All right, do you have another question for our next panel? I'm just let Terry getting up there. Terry, your neighbor.
Hi, my name is Tasha. I'm here as a lifelong resident of Colorado and also somebody who lost a very beloved friend to a heroin overdose in 2017. So first of all, I just want to thank all of you for the incredible work that you're doing. It really gives me a lot of hope to hear how seriously the state is taking this and our elected officials. So really deeply thank you. And then I wanted to raise a question about something maybe a little unusual for this forum, but I think it's appropriate for the innovation panel. So I'm also here today as the state director for a nonprofit called the Healing Advocacy Fund, which is supporting the state to set up the psychedelic therapies program for people struggling with mental health conditions. And here actually at the suggestion of a dear friend of mine who is a licensed addiction counselor in Jefferson County, who used a substance called Ibogaine in his recovery from heroin addiction several years ago and has been an advocate for it here in the state. And under Proposition 122 with the Natural Medicine Health Act, one of the things that we did is created the opportunity for the state to consider a regulated access model for Ibogaine. Just to give a little bit of context about Ibogaine, it shows incredible potential for people with opioid use disorders, specifically eliminating the symptoms of withdrawal and craving over an extended period of time, so not just for a number of days or weeks. And then I just wanted to share something that this friend of mine said to me that really spoke to me about his experience. He said, in the days after my last fix, when he had undergone Ibogaine treatment in Mexico, he said, when I should have been feeling the agonizing symptoms of opioid withdrawal and looking desperately for my next fix, I was instead experiencing the most profound, intense love that I had felt. And for him, that was something that really reconnected him to his community, to his family, and opened up this window for him to be able to move forward in his recovery. And he has been in recovery for a decade now. A long lead up to this question, but I just wanted to ask you, speaking of innovation, What can we be doing to explore this? Because I know that there are concerns, and I want to be upfront that there are cardiac risks associated with ibogaine. And that being said, I think it's incumbent on us to consider this as an innovative tool that has real potential. So how can we explore that? Are there funding mechanisms that we could be considering?
So I'm going to slightly broaden the question, because I know there are other people here who've done things like AccuDetox, which is, obviously you mentioned buprenorphine as a medication-assisted treatment. Obviously we know how important connection and peer counseling is, but what other treatment methodologies are out there? We've got two public health professionals, and ibogaine is one that's been suggested here, and what are the pathways for developing those? Ryan, why don't you go first, then let James. Sure.
I mean, I think one of the things that we need to acknowledge, to your point, is that there is not just one path to recovery. And so I think it's important that we look to build a recovery-friendly environment that allows people to achieve recovery in something that's going to support them. And it's not just MOUD, it's not just 12 steps that have been historically the most popular. To your question, with a substance or medication like ibogaine, there's obviously a lot more steps that would have to take place before that could become something that could be administered in a physician's office like my own. That's going to be a long road as far as, and we're on that road with psychedelics and others right now, where there are a number of case studies that need to then progress to more extensive studies so that we not only know the risks, but we know how to avoid them so that we can administer something like this safely, and we avoid the risk of developing substance use disorder to some of these other substances that are out there. So I think that we are nationally and in the addiction world looking at these studies. Are we going to be in a place a year from now or 2 years from now where we're saying this is going to be a main treatment? I don't think so, but it is something that is important that we keep our minds open to in the purpose of looking at the evidence and not just shutting it down and saying that this is replacing one substance with another, like we have done so long that has caused harm for things like medication for opioid use disorder. But I don't know that we have enough evidence to support that. I think one area that we're going to be talking much more, because the evidence has been more long-standing than something like ibogaine, where we're going to see movement in the next couple of years, is going to be with treatment like contingency management, which is a evidence-based treatment where we are basically utilizing the reward center of the brain that has allowed somebody to develop an addiction, to rewire that using a reward system, an incentive system that is specific to behaviors that are supportive of recovery. The state of California is already is putting into place where this is going to be covered by Medicaid. So I think that's, to your point, Attorney General, that's going to be a treatment we see sooner than ibogaine, but I think these are things that we're looking into.
Do you want to add?
Yeah. I echo Dr. Jackman with the multiple pathways to recovery being a critical element for how we move forward, first of all. Second of all, it took a long time for docs to even get on board with Suboxone and buprenorphine, and that took a lot of provider education. And I think similarly, ibogaine, ketamine therapies, all these psychedelics that we know work for folks, right? We know that. Are going to take a lot of provider education to actually bring them to the forefront as primary models of intervention, right? That said, I know our region is doing some additional learning on psychedelics because we see more folks asking for them, and we want to support them, right? And our team's job is to help you navigate to that thing that will help you, whatever that is, right? And so to that point, you know, it's starting, and we all have a role to play in continuing our own education and spreading that out throughout the region so that folks know the facts about these substances so that they can actually apply them in practice.
I think that's a very important point, is that we just need to be very clear on any treatment that we're pursuing. What are the benefits? What can it actually achieve? What are the risks? And I'd say that we have seen this replicated, whether we're talking about hallucinogens, whether we're talking about cannabis. There are benefits, and we need to not dismiss those, but we also cannot tout any medication as something that does not come without risks.
I want to thank this great panel. People can join me and give them a round of applause. I'm going to ask the Southwest panel to take the stage. We're going to have